right. Well, good evening, everyone. My name is Hamza Ijaz. Welcome to the Society for Academic Emergency Medicine's resident and medical student webinar titled Tricks of the Trade, Clinically Transitioning from Medical School to Residency. I'm a second-year emergency medicine resident at the University of Cincinnati, and I'm a current member at large of the SAEM Rams board. For those of you joining us for the first time, first of all, welcome. Thanks for joining. And the core purpose of SAM RAMS is to advance the future of emergency medicine through the development of our residents and medical student members into future academic leaders. We hope to accomplish this by focusing on a particular set of values that we hold true as an overall organization. This includes knowledge creation, translation, dissemination, professional development, advocacy for education and research, and collaboration, diversity, community, and service. So it is in light of all these different values that we hold that we are actually bringing to you this webinar tonight that is the second in a series of two designed to help graduating medical students such as yourselves into transitioning from your current roles as students into residents in the near future. So in this episode, we'll be focusing on the clinical challenges and how they differ from students versus residents. We will also be focusing on the tips and tricks for how you excel on your different rotations and off-service rotations as well. And we're fortunate enough to be joined by excellent speakers who are experts in this matter, who specialize in medical education and working with young learners. Over the course of this conversation over the next hour or so, please feel free to type out any questions that you may have for the presenters, and we'll try our best to address them during the talks themselves. And then there's also going to be a Q&A section that you can ask your questions there as well. So to start things off, I'd like to introduce our two guest speakers tonight. We are joined by Dr. Sharon Board and Dr. Andrew Golden. Dr. Board is an assistant professor in the Department of Emergency Medicine at the Johns Hopkins University School of Medicine. She attended medical school at my alma mater, the George Washington University School of Medicine and Health Sciences, and then she went on to complete her residency training at Boston Medical Center. She has a focus on both undergraduate and graduate medical education. She serves as the co-director for the required medical student clerkship and sub-I in emergency medicine, and she has been integral in developing new curriculum and exam material, including OSCEs. Her research is primarily in the area of medical education with a focus on student assessment. And on a national level, she is a member of the Committee of Emergency Medicine Residency Directors and Clerkship Directors in Emergency Medicine and is a fellow of the ASAP. We're also lucky to be joined by Dr. Golden as well. He is a first-year medical education fellow at the University of Chicago. He obtained his Bachelor's of Science in Neurobiology and Physiology from Purdue University before attending medical school at the University of Chicago. He completed his residency training and was a chief resident at the University of Cincinnati, where I'm currently training as well. And as a medical education fellow, he currently works as an attending physician in the emergency department and is involved with resident and medical student education. His research interests include workplace-based assessment of learners, entrustable professional activities, and entrustment decisions. So I'd like to thank both of our speakers tonight for joining us. Thanks for coming along. And I think first off, we'll be transitioning with Dr. Board, who's going to be sharing her words of wisdom. So with that, I will let Dr. Board take the lead.
All right. Sorry about that. So my name is Sharon Board. Thank you for that lovely introduction. I think they invited me. I was joking around before the session started as the senior member of the team and of the panel here. Definitely, I am probably of these lovely gentlemen who I'm presenting with. You know, I graduated medical school in 2004 and residency in 2008. So I'm probably presenting or coming at this topic with a slightly different lens than my co-presenter, which is great because you're going to be able to hear about this topic from, you know, someone who's been attending and seen so many residents and medical students kind of go through the cycle of graduating med school, being residents, finishing residency, and then some of our residents stay on as attending. So I get to advise those individuals as well. and kind of seeing that whole cycle sort of repeat itself multiple times. And you just learn a lot about yourself, about your, your role as a physician in the emergency department. And you really gain a lot of lessons learned along the way. We're actually in this talk going to be reflecting a little bit back to my first day of residency. And believe it or not, so like I said, I graduated medical school in 2004. So this was 2004, so 18 years ago. And there are few things that I remember that happened to me 18 years ago, but I remember very clearly my first day of residency. So I got my schedule for residency and a little bit of background. So I did my residency training at Boston Medical Center, like you heard, which is an institution very near and dear to my heart. And when I started training there, so this also will age me a little bit, it was a 2 through 4 program. So what that meant is that I did an intern year in transitional year, medicine, surgery, whatever, I chose. And then we did a 2 through 4 program. So years PGY2 through PGY4, I did my emergency medicine training. So it was a slightly different format. And I think all of those programs for the most part are gone. I don't think there's any 2 through 4 programs left out there. And my residency program transitioned to a 1 through 4 program. So I was doing an internal medicine year at Boston Medical Center, a busy county hospital is where I matched for my internship. And ultimately I wanted to be at the same place where I was doing my residency. So I was okay about it. But I got my schedule and my very first rotation, I'm in the MICU and we have orientation and I go up to the NICU and they're like, we have great news for you. You're on call on the very first day of residency. And I'm sure some of you can probably relate to how you may feel if that happens to you and you start. And maybe Andrew or Hamza have had this feeling, but your heart drops a little bit because you went from being a medical student where you had people overseeing your every move to being a resident where people sort of set you free. And then on top of all of that, they said, ooh, the person you're on call with, the senior resident, she's kind of a little mean. And I was like, oh my goodness, I'm on call with a mean person. And who am I going to ask questions to if I don't know what to do? And then, so already I have this like feeling of dread in my stomach about my night and what's going to be. And then we're doing sign out rounds in the afternoon. And at that time, I don't know if they still do this because I haven't been on a MICU rotation in ages. We would go and we would look at like imaging studies or what happened with patients for the day. We would round as a team in the afternoon. So I knew what to do for the nighttime. My very first day. So we're looking at an x-ray and somehow I was on this service with people who had like crazy bad pulmonary hypertension where this attending brought in all these people and started them on like Flolan, which is a medication where like if it stops or the pump stops working, the patients die in like a minute is what I was told. So I'm in this situation, my very first day of residency, and my senior resident, not the mean one, but a different one, put in a central line. And this was just when ultrasound, I'm dating myself a lot here, ultrasound was starting to use for central lines. And my senior resident had given one of the patients who was on this Flolan pump who had horrible pulmonary hypertension, a pneumothorax. So again, another wave of dread washes over me. And I had this kind of unique, we'll call him MICU attending at the time. And he said, we're looking at the x-ray and he's like, so you're on call tonight. What are you going to do if they call you that she's short of breath? And I was like, I don't know. I'll get another x-ray. I'll examine her. And I was so nervous. And he literally took an angio catheter, 14 gauge angio catheter, and he put it in my coat pocket and was like, you may need to do a needle decompression. And I was like, oh, it's my very first day of residency. I'm like, anyway, I basically stood in this patient's room for half the night and I stared at the patient's monitor to the point where the nurses were like, please leave this room. They were like, we will call you if we need you. But I was so nervous and anxious. And I bring this, like, I tell this story not to scare anyone. The patient wound up doing fine, actually. But more to say, like, looking back, like all of those emotions are still incredibly palpable for me. which is kind of crazy considering that I've been in attending for, 12 some years, 12 years and change. Um, and you will most likely have similar experiences. You will most likely be in situations, and I see Andrew nodding his head, where you felt like this. And Hamza, you're probably still in this mix. And these situations are much less frequent for me nowadays, but every so often they creep in and you get anxious about your job. And that's normal. Our jobs are hard and stressful. And all of that is kind of normal emotions. The other tip that I'm going to put in here for all of you contact lens wearers, do not forget to take your contact lenses out, uh, especially like during some of those first shifts. I was really nervous. And one of my very first days, I can't remember if this was my first night on call or my next night on call, there was a code called, and I was in a new hospital where I really only knew the MICU because we didn't get like this grand tour. Or if we did, like I didn't pay attention or whatnot. And I literally was running to the code with my contact lenses stuck to my, like the insides of my eyeballs. So for all of you contact lenses out there, definitely make sure you take out your contacts before you try and get a little shut eye, because otherwise you will run into issues and you won't be able to find where you're going. I had to like feel my way up the stairs. So those are just some musings for my first day on the job. Now, again, like I said, a lot of these emotions are really very palpable. When you start and you start out an intern year, there's very much this, imposter complex. Like, am I good enough? Am I good enough to be at my program? Am I good enough to write these, for oppressors and to intubate people, to do a central line? And like I said, for the most part, as you go on in your career and as you advance in residency, a lot of that will hopefully go away for you. But it's normal to feel that way. Asking, will I know what to do? I was nervous to write for Tylenol for some people. I was like, will it hurt them? I just don't know. So knowing what to do, I think, is a big thing. And I would caution you to never be nervous to ask a question. And I always encourage my learners, my students, my residents to never hesitate to ask questions, because ultimately, I always say our job as attendings is to teach you things, right? Like if you didn't need to learn things, you wouldn't be in medical school and you wouldn't be in residency, because you would already know everything. Like I would not be in a position to teach you. So if you're unsure what to do, our job is to keep patients safe, and that should be every attending's ultimate goal. And every senior resident, every person who's watching over you, that should be their goal, to make sure that the patient stays safe. So if you are in a situation where you don't know what to do, you're unsure, there's no question that's silly. There's no question that's dumb. All questions deserve answers, right? Will I make a mistake? You will make a mistake. Listen to the words that are leaving my mouth. You will make a mistake. I've made a mistake. Andrew's made a mistake. Hamza's made a mistake. You may have made a mistake as a medical student. And that's okay, right? In medicine, we make mistakes. It's how we respond to them that matters. And I could go on about this for a long time. But if you are in a situation where you made a mistake, talk to someone about it. I guarantee you that person who you reach out to, who you talk to, has been in a similar situation. Will my team be mean to me? Maybe. Will the nurses be mean to me? Probably. And I say that not to scare you, but there are situations where people may be mean, may not be the right word, but they may be frustrated with their situation. They may be overwhelmed with their responsibility. You can imagine that as you're starting intern year, right? All of these people who you're working with, especially like the other residents, maybe even new attendings, are in new roles. They're in situations that they've not been in before. They have new responsibilities that they haven't had before. So keep in mind also that, for some of these people who you're working with, they may also be in a little over their head also, just like you feel like you're in over your head as well. Sometimes nurses, depending on what program you're at, I'm not saying it's right. I'm just saying that it may in fact happen to you that a nurse will question a decision that you make. A nurse will give you a hard time about something. I remember a specific situation when I was, again, an intern, and this was in the ED. And I said to a nurse, can we give the patient a medicine? I can't even remember what. And she looked at me and she said, just so you know, when you ask me that, it offends me, because it's not we doing it, it's me. And I was, again, terrified because I was just trying to be collegial and friendly. So you may be in situations like that, and just understand that some of these nurses have been doing their job for 10 years, 15 years. They've seen, residents and interns start, and sometimes for them, it can become a little bit frustrating or repetitive to be in those situations. Again, I'm not saying it's right, but I'm saying it may happen to you. Will I make friends? Adjust to a new city or role? I know this was covered in another webinar that happened earlier, but this is definitely also something I think that can come into play when you're adjusting, right? Because as much as your life in the hospital matters, your life outside the hospital matters. So keep that in mind again as you're thinking about starting out in residency. What I wish I knew as an intern, some of this I covered already. It's okay to make mistakes. Be kind to yourself and know that mistakes in medicine are very common. It's okay to get upset and frustrated. I can definitely, again, I could tell numerous stories about times in residency that I was really upset and frustrated. And actually, my second year of residency, like 6 months in, I came home and I said to my husband, I said, I haven't cried at work in like 6 months. And he's like, crying at work isn't normal. And I was like, our jobs are just so different. They're so high stakes. And not everyone is going to respond by crying, right? Some people might respond by going home and needing to be by themselves. Some people may respond by wanting to be around people and, have a drink. Some people may respond by running 10 miles. Whatever, you do is what you do when you're frustrated, but give yourself grace. However you respond is okay. It's okay to feel overwhelmed. I always say whenever you feel overwhelmed, run your list. You'll always feel less overwhelmed for the most part after you run your list, especially in the ED. Even as an attending, I follow this rule. Whenever I feel overwhelmed and I have too many tasks to do, I run my list, and it always helps me put things in priority. It helps me put things in order of what I should do and when I should do them. It's okay to have to vent. Talk to your colleagues, talk to close family and friends. Many of you will be going to programs where there will also be resources for you to have conversations with peers when you're stressed, or even with health professionals if you need to. It's okay if you're attending calls risk management. I had an experience when I was a resident that my attending was like, oh, I have to call risk management. And I was like, I'm definitely getting sued. My medical career is over and I'm going to go crawl in a hole. That is not at all what it means. And I always like to bring this up with students because I feel like a lot of people feel like how I feel. And Hamza, you may still feel like this because it happened to me when I was like a fourth year resident and I was really terrified. Remember that risk management is on your side. They're there as a resource to you. They're there to help you out of tough situations, to help you advise you for next steps for what to do when there has been, a challenging patient encounter or potentially a bad outcome. Risk management is your friend. They're on your side, and it does not mean automatically that you're getting sued. I think that's a really good point. The next topic I was assigned, so that's all what I wish I knew as an intern. And I guess this also sort of goes into what I wish I knew as an intern. So what is your job as an intern? Your job as an intern is to learn the basics of emergency medicine, to learn how to be an emergency medicine physician. Your job is not to be the most up-to-date person on EBM. If there's a topic that you're super read a couple of journal articles about it, that's fine. But for the most part, your job is to know how to manage patients with chest pain, patients with ACS, patients with an ischemic stroke, patients with COPD, COVID. The bread and butter emergency medicine topics should be your jam. Many people say pick a book, whether it be Rosen's or Tintinelli, or if there's some fancy new online resource that young people are using that's a good core topic book. Pick it and stick with it. And just go through that resource and that book for yourself. But don't feel the need to read every journal, and don't feel the need to get involved in research from the get-go. Research can be real time suck, and everything from filling out the IR. It can be rewarding, but it can definitely take time to do, especially if it's your first time doing it or you're not super experienced. So don't feel the need to get involved from the get-go. Give yourself breathing room in your intern year to really learn how to prioritize patients, learn the core topics in emergency medicine, get good at some procedural skills like ultrasound guided IVs and the more common procedures that we do in the ED. And I would say that is your main role as an intern. And then when you're not doing that, spend time with friends, spend time with family, exercise, do whatever will bring you joy in life outside of that. So don't feel the pressure to sit home reading through every journal. Instead, use that time to do something that will make you happy. The last topic I was assigned was day-night transitions. And many of you may be youthful and not need any help sleeping. For me, as I've gotten older, I've had more issues with my sleep and my day-night transitions. And as a resident, I was always exhausted. Literally, someone would be like, I would fall asleep while I was like waiting for a lab. They'd be like, the lab will be back in 30 minutes. And I'd be like, all right, I'm going to go to sleep for 30 minutes. And I would full on fall asleep. I'd be out. But as I've gotten older, I've had to use some more of these tips. As a student, I would have been and a resident, I would have been rolling my eyes at this because I would have been like, oh my God, who has trouble sleeping? I sleep wherever. But some of you may have trouble. And some tips that I've learned, and again, this is what works for me and other things may work for you, are sunglasses when leaving the hospital. So when you're leaving after your night shift, put on your sunglasses. It helps, not fully expose your eyeball to bright sunlight outside. Consider melatonin. I've learned recently that Benadryl and like other medicines like that are actually really bad and mess up your sleep-wake cycle kind of badly. So take melatonin, ideally about like an hour before you want to fall asleep. Cool dark room is great. If you can't be in a super dark room, like I don't have blackout curtains in my house, I'm a big fan of a face mask. And I actually have a face mask. I can put the link in the chat if anyone's interested, that has built-in Bluetooth headphones. So I play my white noise from my phone into my face mask and it's super close to my ears. So it's nice and keeps things kind of quiet. And the other thing that I do is on my switch day, I sleep deprive myself on purpose. So I sleep for like 3 or 4 hours in the morning and then I drag myself out of bed. And if my husband was peeking over my shoulder, he would tell you that I'm not generally pleasant person that day. But I try and sleep deprive myself so then I'm able to go to sleep at night. And then this, again, may be a little hard for some of you, and you may not need to do this, but I need no caffeine within about 5 to 6 hours of having to lay my head on that pillow. So for a night shift, I usually stop drinking coffee around like 1 or 2 in the morning. And those are kind of my tips for day-night transitions. Those are the main topics that I was going to discuss with you all. I hope you found some humor and in some of my tales. And I suspect some of you may be reflecting on them as you start your intern year when you have similar experiences, and know that all of that stuff is normal and expected, and to just take everything in stride, one day at a time. When I was a resident, the other thing, you might have already said this as a med student, I can do anything for 30 days. Like even if the rotation was like sucking your soul and like you just did not like it at all. It didn't, it was hard and long hours and people were, it was stressful. I was like 30 days. I can do anything for 30 days. And for the most part, that's all. You have to do a lot of emergency medicine, which hopefully you'll love, but all the other stuff, 30 days is your time limit. Thank you so much for your time. It was a pleasure sharing this information with you. I'm going to now try and end my slideshow and stop my share. And I will pass it off to Dr. Golden.
Great. Thank you so much. That was awesome. Definitely a lot of great tips in there. I'm just pulling up my slides now. All right, hopefully everyone can see that okay. So like Hamza said, I am relatively new at the sort of attending role, but coming to this sort of fresh out of residency. And so I'm hoping to provide just some insight on like things that I found helpful going through residency and thinking back to helping my junior residents transition in this role as well. So feel free to ask any questions along the way too. So if you are not starting to feel overwhelmed, you probably will soon, and that's okay. Like Dr. Board mentioned, this is a very exciting time. There's a lot of big changes happening. And so hopefully, like I said, I can give you some clinical and non-clinical tips that can help you in this transition. So I think the first and probably like one of the most important, I would say, is like these last couple of months of your fourth year of medical school are a time for you to sort of rejuvenate and re-energize yourself. And so I would really encourage you all, I know it's a different world that we're all living in right now, but to try to just like embrace these last couple of months of last couple of months of medical school to just like take time to re-energize yourself. Like I said, don't feel pressured to study or anything like that. Really focus on the transition to a new city and meeting new people and all that kind of stuff. There are once you like start and integrate into a residency program, I think there are probably like two mantras that I live by that I think will like take you a long way both as a resident and also sort of like long-term in your career. And one is just like thinking about your approach to your shifts and your work ethic, I would say. So, you know, the biggest thing I think that will lead to your ultimate success and to make your program and your senior residents happy, but also really be important for your patient care as well, is just how you enter the emergency department when you're walking into your shift. You know, these are all things that I think we sometimes take a little bit for granted, but at the same time, they're so important. You know, like you need to be professional, right? Hopefully you show up early for your shift and you show up ready to work. That's going to earn you a lot of respect with your colleagues and the other people that you're working with in the emergency department. That you have this and sort of embrace this like team-based approach to healthcare that many of us live in the emergency department all the time. I'm working alongside respiratory therapists and pharmacists all the time, asking them questions. And so embracing that team-based approach to care, I think, is really important. And then also just personally, you know, just making sure that your attitude is such that you're willing to learn new things or try new things or have like challenging discussions and really question why you're doing the things that you're doing so that you can eventually learn in the long run. And so I think just like thinking about, you know, every day, like as you're walking into that emergency department, like developing this mind space that is really like embraces all of those concepts that I just talked about. And the second mantra that I still continue to live by is like, if all else fails, if it's just been a hard day and like things are not falling into place, like when all else fails, just do what is best for the patient. We are all here because we want to take excellent care of our patients and hopefully, and I think that if you keep this in mind, that will again, like serve your patients so well. It may be harder, right? You might have to make more phone calls. You might have to ask consultants to come in overnight into the hospital because it's what's best for the patient. But if all else fails, like this is the mantra that I hope all of you guys live by as you go through these next 3 or 4 years of residency. So I am just going to briefly touch on a couple of resources that are sort of like ways of learning, I guess, and like styles of resources. We can certainly, if there's interest in, you know, the Q&A, talk about other resources for learning EKGs or learning procedures or things like that. But I'm going to echo a little bit of what Dr. Board talked about and sort of like the utility of how you should frame your learning now. I think that as you are transitioning to your intern year, your first year of residency, like learning the fundamentals of emergency medicine is so important for your future and how you will be learning in the future. And so getting that really good sort of set point of by reading like, you know, the basic fundamentals of approach to chest pain, or like if you have a specific disease pathology like aortic dissection, like learning how to manage those really well. And a great resource and a great way to do that is just through like the normal sort of textbooks and online resources that you hear about. So Rosen's and Tintinelli's are like the most popular textbooks for sure. But there are so many other resources available to you as well. But I think that using textbooks, and you don't have to read them front to back, but using a patient encounter, saying like, man, I really should learn more about, you know, hepatorenal syndrome, and just going to a textbook that day after you leave from your shift and just like briefly reading about it. This is still a practice that I use every day. I try on shift to find like to read at least one thing about one patient that I see in that day, whether it's a primary research article or a review article. But you'll hear a lot of people, and I'm just referring to some of the other resources that you may hear other residents use. So like question banks are very commonly used. And most people use these sort of as they go like approach standardized tests. So in case you're not aware, your standardized tests will not go away. You have at least one per year for the next 3 or 4 years. But these are great resources to study for that. But the challenge with question banks is that it assumes that you have fundamental knowledge that you're applying to a common clinical scenario. And so I wouldn't use these right off the bat to sort of like test your knowledge, because you have to develop that fundamental knowledge from the beginning. One way that you can do that, and one way that a lot of people do it, is through the use of like blogs that are very popular nowadays with free open access medical education. But again, most blogs aren't peer reviewed, and they may sort of describe like newer techniques or newer approaches in that haven't been fully embraced by the emergency medicine community. It's not that they're wrong. It's just, again, I think like you want to learn the fundamentals of emergency medicine. And so blogs may not be the best place to do that. Other really common ways that people learn are through podcasts. So MRAP is very, very popular amongst residents now. For me, I don't learn best by listening, but people really love it. And there's really great segments on this podcast, on that podcast in particular. There are so many though. I also found for me, like I would inevitably listen to these podcasts, like driving to and from work. And I wanted that 15 minutes to just like focus and not think about medicine and just sort of like relax before what was inevitably going to be like a stressful 8 or 10 hour shift. And so that was just one way that I could sort of like really focus, was eliminating those from my study regimen. But as Dr. Board mentioned, like you'll talk about literature, and I hope that you do read primary literature, but this should not be the fundamental way that you're learning at this point in your career. Certainly as you are more advanced and a senior resident, like reading the newest journal articles is going to be important for continuing to refine your practice. But right now, the way that they may take shape is, right, if you go home and read about strokes, for example, in a textbook, like then finding articles about like, is there evidence for TPA, or what's the evidence for thrombectomy through like the Dawn trial, for example, and reading those like fundamental sort of groundbreaking literature pieces that have been published in some of these like seminal things that we do in the emergency department. But I think the most important thing is you are going to be most of your time working, right? You are going to be, as a resident, your schedule is not light. So embrace the on-shift learning that you can do. We all want you to be curious. We want you to feel comfortable asking questions. And so make sure that as you're on shift and if you're not sure why something is happening, or why your senior resident or attendings are asking you to do the things that they're doing, like make sure you ask about it. And that's a great way to learn. So that's just a little bit about like my approach to learning, especially as you transition into this new experience. But I'm just going to focus on 4 other things that I sort of wish I knew. And I actually polled my other chief residents who are now out practicing in the world, and want to share what they said. And again, a lot of this echoes what Dr. Board had mentioned, but mine is share your experience. So I think in medicine, we commonly sort of like have this stoic, we can't show our weaknesses approach. And like, I would love to be one of the people that breaks down those barriers and allows us to talk to each other about the difficult times or the mistakes that we make. And you can do that. You for the next 3 or 4 years are going to have a core support system in your co-residents and their families and your family. And so if you have a bad day, talk to someone about it, because I will guarantee you that someone else is going through the exact same experience or has gone through the exact same experience that you are going through. And if someone comes to talk to you about it, be supportive and be open to discussing those. But in the same time, celebrate your successes, right? You guys are all going to be doing great things and getting appointed to positions or getting, different publications or whatever. So make sure that you celebrate those successes as well. All right, this is a quote from one of my co-chiefs, Catherine Banning, who's currently in community practice in Tacoma. But she said, just sort of going along with what I was talking about before, that she wished that she had used the time to ask so many questions. It's a time to expand your knowledge and build your foundation. So I think I was too busy trying to please my attendings and my senior residents and not look stupid. And I didn't understand the why of why we do the things that we do. This probably resonates with many of us who practice, of like that transition to first year being really tough. And so don't be afraid to ask questions. We want you to ask questions. We understand that people are coming from different backgrounds with different educational experiences. And so we want to like set the playing field and get everyone on the same page before you start to like take off in your career in emergency medicine. All right, I love this one. This one is from Jared Ham, who is a neurocritical care fellow still at the University of Cincinnati. And he said, train your weaknesses until they're your strengths. Don't like LPs, look for chances to do them until you're not afraid of them. This goes for so many things, but let's talk about just procedural training first. So there's a lot of procedures that we are within our scope of practice in the emergency department that you just maybe won't do as much. For me, like when I was getting done with first year of residency, like subclavian central lines, I still felt pretty uncomfortable with. So whether you're doing those in real clinical practice or spending time in the simulation lab practicing, just make sure you're training them so that they're your strengths. But this quote really applies to anything, right? So if you're giving a lecture to your residency, give it on a topic that you feel uncomfortable with, because you're going to learn a ton about that topic and it's going to make you stronger. Or if you're working in the emergency department, pick up patients that may be a little bit more challenging or chief complaints that you're less familiar with. And if those are your goals, make sure you talk with your senior residents or your attendings about it on shift so they can help you to achieve those goals too. All right. The next thing is, so this is just like this concept of and breathe. We sort of talked about it a little bit, but this is a quote from Mike Klasky, who is a critical care fellow at the University of Washington. And he said, I wish I knew how to better organize my life, and that being a resident wasn't my entire life. So build in time to exercise, relax, pursue hobbies, but actually planning it instead of just waiting until I had both the time and the desire. This is key. And I don't have a great sort of one size fits all for everyone for this, but early on in residency, figure out how to make this sort of work for you. For me, like I love to run. I've started playing the piano, so I like make sure that I try to integrate that into my daily routine. And certainly as a resident, I hope that you can do that as well, to just make sure that you have a life outside of the hospital. All right, I'm going to end on my sort of last slide here. So you got this. It is very common as you transition for this concept of imposter syndrome to sort of rear its ugly head. But I just want to reemphasize, I see some familiar names in the chat, but you are not here by accident. And I just want to reemphasize to you that the system works for a reason. You've put a ton of hard work into the last 4 or 8 years, or however long you've been preparing for this transition to emergency medicine residency. And so you deserve to be here. And you got this. You'll have a great support system wherever you go. Just make sure you tap into them, ask questions, and just be like ready for a really awesome and crazy experience. So with that, I'm going to turn it over back to Dr. Ijaz, and we can answer any questions that you guys have.
Thank you so much, Dr. Golden, Dr. Board. This has been super helpful. Thank you so much for sharing your sage of advice here today. So many points that you have mentioned, even I can relate to directly myself, even as, soon to be a 30-year resident at this point. But one of the questions that, came up was, we was alluded to earlier about the relationship with nurses, but Dr. Golden, can you talk a little bit more about the importance of developing a collegial relationship with the ancillary staff that includes your nurses, the medics, the pharmacists? Why is all that important?
Yeah, for sure. So I think, so like I said before, I mean, you guys have all rotated in the emergency department. You understand that we function as a team to take care of patients. I can't just order people around and expect things to magically happen. Like, we all put in a lot of hard work to take care of patients in the emergency department. And so I think that the relationships that you build with your ancillary staff you'll help to like you guys as a team will collectively take care of patients better, I would say. But you can also learn so much from those people. I remember I think I was probably a first year resident, like walking into a patient's room and saying like, hey, I'm Dr. Golden, I'm gonna be taking care of you today, while all these other people are surrounding me, like helping to start IVs and draw blood and give medicines. And I remember the nurses being really sort of annoyed that like I was taking credit for their care. So now I make a point of, especially when I'm in the room with nurses and techs, like we as a team are going to be taking care of you today when I introduce myself to patients. But I think the other side of that too is that you can learn so much, especially as a early resident and medical student. You can learn so much from those support services and ancillary staff that are in the emergency department. I still go to my pharmacist in the emergency department all the time to ask questions. And very early on in residency, I would actually ask the nurses and other people I was working with for feedback too. So I would just make sure, like, as you are moving along, to integrate them, like in asking about feedback, just seeing how you can work better within the team structure of the emergency department, and how you can help, you know, sort of their role as a nurse or whatever ancillary staff you're working with.
Thank you for that.
And also add on quickly the medics as well. I don't know if I heard
for sure. Yeah.
Medics.
Yeah.
The medics can be your best friend and are also an amazing resource for patient information. So being friends with the medics is also really, I think, an ancillary staff that sometimes I think gets left out a little bit. But be friends with your medics also.
And then not to forget social workers as well. They're honestly, without social workers, if your institution doesn't have that or the emergency department doesn't have it, I don't know how I could function without them. They're able to find so much information in a pinch, and it's incredibly useful. You know, emergency medicine is almost social medicine, you know, in a way. There's so many different aspects of it. So without their support too, it would be hard to do our jobs. So thank you for that, Dr. Golden. Another question came in. This is for Dr. Board, and it's the second year resident who formerly was into a surgical specialty, but has now switched into emergency medicine. So the question for you, Dr. Board, is as a re-intern, do you have any suggestions for how to best aid co-residents during, you know, their new year, their new intern year versus, you know, this individual's second year?
Yeah, so I answered this individual individually because from the message, but I think that the best thing you can do is to tell them, like, look at me, I survived till the end of intern year. I'm still here. You know, I think similar to what I was talking about, you know, what these other panelists and moderator has seen, you learn, it's a very steep learning curve when you start residency. And you know, even though you only have a single year under your belt, you still have a ton of knowledge about how hospitals work, how ordering things work, how, you know, a lot of the logistics, even if you're at a new place, right? Like it still is, you know, you can bestow so much information, like a wealth of information upon these, you know, these new interns. And I'm sure just like they can learn a lot from you, you can probably also learn something from them, right? We all have things to teach each other along the way. So I would say just be a support system, bake them cake. No, I'm just kidding. Sweets and chips and sweets can go a long way. That's another good tip, right? So if you want to get in good favor with people, bring in some cookies. It doesn't have to be fancy, especially on night shift. It's a fact. One of my former co-residents did a presentation that med students like rate your course better if you give them out cookies. So it's, I'm like, I can't believe this was a study that was done, but it was. So I would say that those are just the big things. Just learn from one another and offer up, you know, whatever resources you have or tips that you've learned along the way.
Thank you for that. I had another question for Dr. Golden as well. This kind of goes more so particular to your intern year. We come into this with having to do, obviously, our emergency medicine months when we are expected to do 5, 6, 7 months, depending on where you're training. But then you get accustomed to that environment, but then you're asked to leave the department and go to your OBGYN rotation or an orthopedics rotation or a medical ICU rotation or a trauma rotation, or, you know, what have you. When you go to these off-service rotations, you're basically starting from scratch all over again. And Dr. Board, feel free to chime in as well. But what is your mindset when you're thinking about these off-service rotations, and what advice would you offer to Dr. Golden about making that transition to these different off-service rotations?
That's a great question. I mean, I think a lot of us, all of us went through our off-service rotations, and at your institution, like some will be better than others for sure. But I think like the approach that I always took when I went into these was like, what as an emergency medicine physician do I need to learn and get from this experience? And I think you can be honest with the people that you're working with, right? I think like OB is a great example, right? Of like, if you have a patient who is having postpartum hemorrhage, like, what do I as an emergency medicine physician, like, how should I approach this patient? What should I be like thinking about while I'm calling you guys on the phone, or if you're in the community, if you're managing this yourself? I think that approach of like asking very specifically, like, what can I do? What should I be focusing on as an ER doc? And what should I be learning? I think the other thing that is really helpful at most of the places that you guys are going to be working is the relationships that you build during these off-service rotations are going to be extremely important as you go through the rest of your residency training, because you're going to be talking to those people all the time for consults or admissions. And so if you get to know those people well, and you guys respect each other's clinical care, and can hang out and talk about your experiences in the MICU together, whatever, it makes your sort of day-to-day life, can make it a little bit better. But I always say, like, I loved most of my off-service rotations, and I feel like I got a ton out of them. It should always be career reaffirming that you, like, at the end of your like 2 weeks or 4 week rotation, to like just be so happy to come back to the emergency department. And I always found that, like, I had great experiences, but I was just so happy to be back.
Yeah, I mean, the advice I gave earlier, you can do anything for 30 days. It's probably not the best advice, but it's sometimes a little bit realistic, right? But I agree with everything that you just said. I think the most important thing is to get out of it what is going to be helpful to you, right? So you want to deliver babies because like people are going to be coming in labor. Like you want to know how to do that. And doing it on the OB service is way better than doing it in the trauma bay. They have all the stuff you need. Same thing with like an ortho rotation. Like you don't want to go to the OR for hours, but you want to know how to reduce a distal radius fracture. So go with them to do that. A lot of times also something to keep in mind is a lot of times these residents don't like taking the consults in the ED. So go do the consult in the ED.
Yeah, for sure.
Volunteer to do that. You'll put yourself in everyone's good graces. If you're like, hey, I'll go do the ED consult, they'll be like, okay, sounds good. Let us know what you need. I think that's another, and I see our ED residents doing that all the time where they're like, oh, we just come do all the ED consults so we don't have to go to clinic and like we don't have to spend all the time in the OR.
Like the discharge summaries.
Goal. So, yeah.
Both of those facts so true. And honestly, the discharge summary is inpatient, so dreadful. But
yeah.
If I can get out of doing that and go see a consult or something in the ED where I'm in my own comfortable space, I'd be happy to do that. And honestly, the fact, Dr. Golden, when you were mentioning the fact that you get to work with a lot of these, colleagues that they'll be consulting in the future, or you'll be, once you've rotated with them, you can leverage that relationship that you develop over the course of the 2 weeks or the months to help you out when you're in a pinch or taking care of a really stressful circumstance. Those relationships you end up building over the course of your intern year with your off-service colleagues will come to pay dividends second, third year, or fourth year, depending on where you go. So I think that's really important. And honestly, segues into my next question. And feel free to take this, either of you guys. But essentially, it's talking to consultants. I remember as a medical student myself, I had to practice my presentation or practice my admission with the attending or the resident I was working with before I then made the call to the admitting service or call the consult. And it was terrifying. And as an early intern, those thoughts were in my mind when I'm like, why am I calling them? Is this a stupid question I'll be asking them? And does this person really need to be admitted? So the question is, how do you kind of channel those, channel what you need to do to basically get the patient admitted or to ask the right consult question when you're talking to a service colleague or consultant?
So when in doubt, you just say, my attending's making me call you. No, I'm just kidding. Don't do
Walk away from the desk and say, my attending's making me.
In all seriousness, I'm joking around. You shouldn't do that. It's really interesting that you bring up this question. I feel a little bit as if this art of calling a consult is a little bit of a dying art, especially with Epic. Right. I find that our consultant services now, what they do, and maybe this is different at different institutions, but I find that what our consulting services do is we page them and like through Epic and we put a little message in there, and then they go and they like stalk the chart and like read all the notes. And then they call you back and they're like, what's up? And they already have all of the information. It's kind of like after you see a patient and your attending has already like done all this like digging, and then you present your patient and they're like, we know. All that being said, like I do still think it's very important for you to be able to convey to your consultant in a quick fashion what you need from them. And the key teaching it and what everyone says is you need to have a question for them. And that's ultimately what it comes down to. They want to, and different services will want more information from you, right? So the surgeon wants, for the most part, like a 1 or 2 liner. And how quickly they need to get there. Like, is the person rupturing their aorta? Do they have appendicitis? Or, do they have a low-grade bowel obstruction? Like, they need to know, like, how quickly they need to be there. And then they need to know what you want of them. And I think those are like the 2 key things in emergency medicine. Like the neurologist may want more information. And sometimes those neurology cases are more complex, right? Like they've had this symptom for a year. And so sometimes that gets more nuanced and more complex. But for the most part, they want to know, do they need to run or walk? And what do you need from them? Like, how can they best help you take care of your patient? And in different situations, that'll be different. Sorry, my dog is squeaking a toy like crazy. If you hear him in the background, he's making me like fight with, like pull off. It's a puppy. So that's kind of my consult advice. But I do think that it's gotten easier over the years with technology.
For sure. And I think I would just echo, I think probably the biggest thing, like one of my like soapboxes, I guess, is just like I just want to give them a heads up consult. And I think like there are some times where that's appropriate, like a recently post-op patient, who is potentially having a surgical complication. But like most of the time, I would say try to have a clearly defined question that you're asking your consultants, because you need to know why you're talking to them. But
yeah, I mean, honestly, once you work on these off-service, once you do these off-service rotations, you'll be the consultant to a lot of your ED colleagues. So that when you get a consult and there's a long-winded story about, chest pain and then belly pain and then 10 years and then 2 years and then today this happened, your train of thought is, lost. So you're basically have to think as the consultant, what is the most salient points of the clinical presentation that you want to convey? So it usually helps to start off with the question itself. Hey, I'm consulting you because I think this patient's got appendicitis, or because this patient's got a hip dislocation, and then talk about, well, they fell down and et cetera, whatever the story is. I feel like that's really helpful as having been on the other side as one of these consultants when you do these off-service rotations. But yes, definitely career reaffirming when you were back in the ED, working there for sure. So I want to take a slight change of direction in this conversation. Dr. Golden, the next question is towards you. This is something that maybe medical students don't necessarily think about as much in the transition, but it's something that it's real day one and it's never going to leave medicine, and it's documentation. It's a difficult aspect. It's not something that I feel like medical students are exposed to during medical school itself, or as the same salient points that we need to be aware of. And it's hard when you're a brand new resident, an intern, learning what do I need to write down? What do I need to write in the MDM or the medical decision-making part of this? How detailed or lack of detail do I need to be? Do I need to write a full paragraph? Can I write a couple of lines? At the same time, you have to manage and juggle multiple patients. So can you talk a little bit more about some of the tips and tricks that you might have for good documentation, and then also trying to be efficient at the same time, which are both obviously hard to do when you're an early intern?
yeah, this is a huge topic. So I'll try to give a couple pointers. So I think one is that like most places will sort of talk you through what's required for like billing purposes, and that's a whole other separate lecture. But I would say that you guys, I think your priority is to document what you think or know is important about your clinical encounter, right? So in your history, like going through the full like descriptors of pain and like all the other associated symptoms that could be related to what's going on. Document the exam that you actually do, right? Like every time I see an exam for an ankle sprain that says that, you know, their cranial nerves are intact, I'm just like, I know that that was not actually done. So if you're using templates or things like that, just be cautious of what you're doing. And I think that the other thing, and now having been at two different institutions that have like slightly different approaches to the timing of documentation and sort of how things work, I would say that in order to like maintain clinical efficiency, the recommendation that I always give is like as you go throughout your shift, if you don't write or at least start writing a note for the patients that you have seen, you're going to forget that information. And so my tip is always like, when you're done seeing the patient or seeing like a couple patients in a row, if you're batching them, at least do your like the HPI and the physical exam for those patients so that you have that information pulled into your note and documented. And then like as you are going through your clinical decision making and through their course in the emergency department, you can continue to update that note later on. But what I would really recommend, probably the biggest piece of advice I can give, is talk with your attendings and your senior residents and just get their tips, because the practices that you form during this first year of your residency will probably last for most of your career. And so develop the right practices and the good practices now so that you don't get to the end of your shift and have 20 notes that you have to complete. I think like just try to sort of talk with the people who you're working with to get their tips on how to do this. But I would say for me, it was always documenting the HPI and the physical exam immediately after I saw the patient. And then I guess the other tip I would add is like finish their note when you're dispoing them. So whether they're being discharged or admitted, just like finish your medical decision-making portion of that chart. So that way, theoretically, like you only at the end of your shift have to sign the notes that you're signing out to the oncoming provider. I don't know, Dr. Board, if you had any other thoughts.
No, those are all great tips. I think documentation is something that's really hard to keep up for new residents, and getting in good habits with it will absolutely put you in a really good position moving forward. I totally agree with getting your HPI down in there, because that is ultimately the most detailed part. So if you get that in, and like I don't know, I feel like if you get the HPI there, you can always kind of reflect back on it, and it'll help you remember the patient for the most part. If you're in a situation where you're not able to finish your note. I did put in the chat, document only what happened. Again, like you may be involved in a stressful situation where a consult is doing something you don't agree with, or, you know, there's like something controversial that happens with the patient. Only write what happened. Do not throw other people under the bus. It is not good practice. You do not want to be thrown under the bus ever, right? And in a note. So never, like, take your emotions, put them down there, kind of takes 4 deep breaths, and then write just what happened. Do not write speculative things. Do not write something about a consultant doing something that you think is inappropriate, right? Ultimately, we're calling them because they are the specialists and they are the experts in the field. And if that's a decision that they're making, like you can work around it a little bit, like you can do whatever, but don't write like they made a stupid decision. In not those words, obviously, but in other words, write what happened. Same thing with what a patient says to you, write what happened. Do not, again, speculate all sorts of things.
Those are excellent points. And Dr. Golden, when you mentioned, trying different things or asking questions, I think a lot of residency, and I think we're getting close to the end of this, can be summarized by asking questions in a lot of different ways and trying different things, trying different ways that you treat chest pain or abdominal pain or work up abdominal pain, asking your co-residents how they manage night shifts or how they do different procedures or how they work up different complaints, asking your attendings the same questions. You guys will be entering a very unique phase of your career very shortly in a few months. And this is the time where you'll be able to ask whatever question you want, because it's going to shape how you're going to practice for the next 20, 30 plus years. So this is the opportunity to ask and try in different ways of documenting or different ways of doing a procedure. So don't hesitate to ask that question. I know as a medical student that can be daunting I don't want to seem like I don't know or I'm going to seem, I'm asking a silly question or stupid question. There is no stupid question. Feel free to ask whatever is on your mind, just because, might be the only opportunity that you might have to learn for the next, or at least you'll be dedicated to learn, as a resident. So please make that effort over the next 3 to 4 years. I'm excited for everyone who's here, who's going to be joining our awesome specialty. Thank you so much for Dr. Golden, for Dr. Board for joining us and being our guest panelist today. Thank you to everyone who's joined this webinar as well. Thank you all for everything that you guys do. And I'm looking forward to seeing you guys on a future webinar as well. So everyone, you all take care and have a good night.
Thank you. Happy Doctor's Day.